Good evening, everyone. Welcome to the webinar on how to make sense of data from ASCO GU 2026. Now, I would like to invite our program director to start with the proceedings, Dr. Amol Akhade.
So
So
thank
over
you.
to you, sir.
Thank you, everybody. This is our sixth webinar and as a part of the Onco Circle. Today we'll be talking about how to make sense of data from ASCO GU 2026. And our first speaker is my colleague, Dr. Neelam Singh. She is assistant professor at AIMS, Bhubaneswar, India. And she will be talking about what is the recent data that was presented in ASCO GU 2026. So over to you, Dr. Neelam.
Good evening, everyone. Are my slides visible?
No, I think you need to share them.
Yeah, sure, sir.
Hello, Professor Yüksel.
Hi, Amol, hi, all colleagues.
Thanks for joining.
Of course, thank you for the invitation.
Yeah, we're starting with the first talk from my colleague, Dr. Neelam Singh. Neelam, over to you, please.
So, good evening, everyone, and I would like to thank Amol sir for the opportunity. Without wasting any time, so let's go ahead with the topic of discussion. So, today we are going to be discussing on how to make sense of data from the ASCO GU 2026. This slide where we see that these are top trials that were discussed in the ASCO 2026. So I'm going to be discussing the top three abstracts, and then we'll be having some, maybe I'll just summarize a bit. So going ahead with the first abstract, so it's a phase 3 keynote B15 where neoadjuvant and adjuvant enfortumab plus pembro for participants with muscle invasive bladder cancer who are eligible for cisplatin. So as we know that even after surgery, in this subset of patients, survival is somewhere that is less than 5 years. So hence this was something that was really necessary. So in the keynote B15, the eligibility criteria, as we can see, that the adults with the muscle invasive bladder cancer with the stage T2 to T4 and T1 to T4 with the node positive, the urothelial histology. So as we can see, these were the key eligibility criteria, and they were randomized in by 1:1. In first arm, there were 405 patients with enfortumab plus pembro, and the other was gemcis. And again, post-surgery, they had received enfortumab 1.25 mg per kg 5 cycles, with pembro around 13 cycles, and the second arm post surgery, it was observation. The primary endpoint was event-free survival, with key secondary endpoints being the overall survival and the pathological complete response. So here, if we look at the statistical considerations, so this is something that I would spend some time. So it actually used a hierarchical testing strategy for the alpha allocation. So we can see that the overall type 1 error rate was controlled at an alpha of 2.5%. So if the event-free survival was statistically significant, then the test then only the testing was continued. So 96% of the alpha was transferred to the overall survival, and 4% of the alpha was transferred to the pathological complete response, and the overall survival and the pathological complete response was tested according to the graphical structure. So the first interim analysis was planned to occur when 254 EFS events were observed, and 18 months after last patient was randomized, and if event accrual was slower than expected, the first interim analysis could be triggered 18 months after the last patient randomized. So this was a definition for the EFS. So looking at the baseline characteristics, we can see it was pretty much well balanced in both the arms, and as per the age, tumor stage, and the creatinine clearance and others. So coming to the primary endpoint, the event-free survival, the hazard, we can see that there is a hazard ratio of around 0.53, showing a 47% relative risk reduction in the risk of mortality, with you can see at 12% around 86% EFS benefit, and around 24 months around 79.4% of EFS benefit. Even if we look at this subgroup analysis, we can see that all subsets have majorly benefited with the EV pembro arm, and here, as I can emphasize, you can see that irrespective of the PDL1 status, both more than 10 and less than 10 have benefited with the EV Pembro. You can see some places where it has crossed. One is because of the low event numbers. So again, going to the secondary endpoints, the overall survival, here we see a hazards of around 0.65 with 12 months around 93.1% and 24 months around 86.9%. So again, here as well, we can see in the subgroup analysis on the overall survival, we see that there is a benefit in all the subsets, and it does favor EV Pembro. Again, if we look at the pathological complete response at the ITT population, we see an absolute benefit of around 23.4%, and in EV Pembro, around 226 patients were operated with around 55.8% PCR rates. And again, if we look at the toxicities, so around 63%, around 75% of the patients had around more than equal to grade 3 adverse events. And yeah, the most common adverse events, as we see, is some pruritus, diarrhea, alopecia, anemia. So these are some of the common adverse events noted. So again, to conclude that the neoadjuvant and adjuvant EV does significantly and meaningfully improve the EFS, OS, and PCR rates. So going to the next abstract. So here I'll be discussing the piece 3, the URTC 1333. So its final overall survival results showing enzalutamide with or without radium-223 in the metastatic CRPC. So again, as we know that we have a study, ALSIMCA, where it did show an OS benefit with the addition of radium-223. So here, if we look at the study design, so it does include patients with CRPC, with bone metastasis, and the other factors, as we can see over here. Again, it was randomized in 1:1, the first arm being enzalutamide with radium-223, 55 kilobecquerel per kilogram. So every 4 weeks for 6 cycles, and the second arm was enzalutamide alone. And here the primary endpoint was radiographic progression-free survival, with the secondary endpoints being the overall survival. So here also, as we can see, the statistical design was pretty much event-driven. So for the primary analysis, 283 radiographic progression-free survival would have happened, and then we can see that it was tested in a very semi-hierarchical way, and the OS was tested in a one-sided alpha of around 0.034, and the final OS analysis was tested at the remaining alpha that was around 0.0248. So if we look, so there is a 70% probability to detect 25% reduction in the risk of death if the true HR is around 0.5 as per the specified alpha value. So again, here we see that the baseline characteristics, it's pretty much balanced in both the arms. So looking at the final overall survival results, as we see that the separation of curves are more noticed after about 12 to 18 months. So it does show that the radium-223 effect does increase over the time. And we can see a hazards of around 0.76, and we can also see the benefit over 6, 12, and subsequent months. Again, looking at the survival status, so before the intersection of the curve, the overall survival difference is observed at 12 months and is only 6 patients. And if we see regarding the deaths before the 12 months, the difference is just 4 patients. Whereas if we see beyond 12 months, the death increases more in the ENZA alone arm. Again, so the treatment effect is reduced in older patients, that is equal to 75 years or so. We do see a benefit in patients who are less than 75 years. And again, if we look at the final radiographic progression-free survival, we see that there is separation of curves and it is sustained. And when we see a hazards of around 0.71, and also the survival benefits, the radiographic progression-free survival benefit over subsequent months. Again, looking at the safety summary, we can see that around 63% of the patients had around a grade 3 to 5 drug-related adverse events. So the key takeaway points, the combination of enzalutamide and the 6 cycles of radium did demonstrate a significant overall survival benefit. So this is something that we can use as a first option, as an option in the first line treatment for metastatic CRPC with bone mets. Now going to the third abstract, so that is the LightSpark phase 3 LightSpark 022. That's the adjuvant Pembro plus belzutifan versus pembrolizumab for the clear cell RCC. Again, here, if we see the key eligibility criteria, so the histologically confirmed clear cell RCC, surgery done less than 12 months. So again, they had included intermediate high risk of recurrence patients, PT2 grade 4 or sarcomatoid, N0, PT3 any grade, and the patients with high risk of recurrence, that was PT4 any grade, N0, any PT any grade, and M1 NED. So here you can see again, it's 1:1, Pembro for 1 year plus belzutifan for less than equal to 54 weeks, and the second arm was pembrolizumab plus placebo. The primary endpoints, as we see, the disease-free survival, and the key secondary endpoints being the overall survival. And again, they also had used the stratification factors as per intermediate high versus the M1 NED and the tumor grade. So again, I believe they had also had the statistical considerations. So for the DFS, 496 events estimated to provide 95% power to detect hazards of 0.72 at an alpha of around 2.5%. And again, the median follow-up was around 28.4 months. And I believe we'll be discussing it subsequently in the panel discussion as well. So again, looking at the baseline characteristics, pretty much well balanced as per the age, tumor, the risk categories, and the stage and the PD-L1 status. Looking at the DFS benefit, we see something where some very good curves where there's early separation and there's sustained separation of the curve that we see with the hazards of around 0.72 and at 12 months around 91.9%, with at 24 months around 80.7%. Again, in the subgroup analysis as well, we do see that almost all the subsets have benefited with the pembrolizumab with belzutifan arm. And again, looking at the interim OS results, the graphs are pretty much overlapping. But again, we can see some encouraging data. But again, we'll have to, the data it still is immature. But again, we can look the hazards of around 0.78. So looking at the safety results, so around 40 to 50% of the patients had treatment emergent acute events and the treatment related adverse events. So again, here as we see the side effects being anemia, fatigue, this has been the common side effects that we see. So again, to summarize, Pembro with belzutifan did show a statistically significant and clinically meaningful DFS improvement versus pembrolizumab monotherapy in patients with the clear cell RCC who have an increased risk of recurrence. So I would like to discuss some practice-changing top 5 abstracts from prostate. So my take on that. So P3, as we discussed, that is something that is practice-changing. The PSMA addition, obviously, frontline PSMA therapy is a milestone. Sequencing will change, but capital 281. So obviously, with the advent of capivasertib, so biomarker testing must be routine for implementation. Piece 2, systemic intensifications remains controversial, but patient selection is key and BRCA away. The concurrent strategy optimizes efficacy, and early molecular testing is essential. Likewise, the top bladder cancer highlights, that's Keynote B15 as we discussed. So this is something that is practice changing. IM Vigor 011. It does validate the ctDNA guided therapy, and very, very impressive data that came from the Niagara biomarker data that showed a 24-month EFS, 90% in ctDNA and the urine tumor DNA negative subset. So yes, molecular surveillance is transformative, and urine tumor DNA could redefine the follow-up. And the sacituzumab govitecan, the TROP2. So this also expands the antibody drug conjugate portfolio, and thus obviously sequencing with EV and IO, that will be very important. And the last, Sunrise 2. So yes, bladder preservation is promising, but obviously, for now, CRT does remain superior. So 5 key abstracts from the RCC, the LightSpark 022, as we discussed. So again, it's something promising, but yes, the OS data are immature. The RAMPAT, it does strengthen the adjuvant IO case, and biomarker-driven selection is needed. Again, the Cosmic 313, the triplet therapy is powerful, but yes, tolerating limits the real world use. And the cytoshrink, the virtual nephrectomy is innovative, but data do not yet support the benefit. And the last, LightSpark 011. So belzutifan combinations are the new second line leaders. So the sequencing is something that must be clarified. So with this, I would like to conclude and say the transformation of geo-oncology is no longer defined by aiding agents, but by integrating biology, And I would like to wish everyone a happy Holi from the entire team of AIMS Bhubaneswar. And thank you
Thank you,
all
Dr.
for the
Neelam.
patient hearing.
Thank you. Thank you. Thanks for this lucid talk. It is very difficult to summarize the entire 3-day conference in 15 minutes, but you did a good job. So moving on, I think we will start with our panel discussion, and we have extremely well faculty. We have Dr. Bicky Thapa, we have Dr. Deborah, Dr. Hans, Dr. María, Dr. Professor Yüksel, and our own Dr. Senthil. So I thank everybody for joining. And let me share my slides. I hope they're visible. Yeah. To start with, I have no conflict of interest. Let me declare that we appreciate efforts taken by all trialists and sponsors for conducting clinical trials. All trials, be it positive or negative, add to our knowledge. Aim of this discussion is to understand granularity of new data and way forward for our clinical practice. Ultimate goal is improvement in outcomes of our patients. This is very difficult to cover all the data. So let's start with the kidney cancer. Now, of course, we have two important trials, the LightSpark 011 and 022. LightSpark 011 is the second-line trial, belzutifan plus lenva versus cabozantinib for advanced renal cell carcinoma after anti-PD-L1 therapy, open-label phase 3 trial. Now, let me start with Dr. Deborah, if you are here. Now, if you see, the majority of the patients received in the second line, 43% no prior TKI. So are you okay with the prior therapies? It's quite a heterogeneous group. So your thoughts on this, Dr. Deborah or Dr. Yüksel?
Absolutely. I think this probably reflects real clinical practice. Perhaps where I work, patients are more likely to have a TKI plus IO combination in the first line. We're trying to get that improved tumor shrinkage up front. I think we have less use of dual IO therapy in the part of the world that I practice. But I think this does reflect a real world population of first line regimens. It is very heterogeneous.
So what about those patients who may have got prior lenva as a part of pembrolizumab or nivo-cabo? So they have not given this, the analysis of how many of those patients, probably how in the final publication they will give. But what are your thoughts on this, Dr. Yüksel?
Thank you. Actually, agree with Deborah. Also in Turkey, IO plus IO is now reimbursed. So for most of the patients with kidney, we both use IO plus IO or IO plus VEGF. But of course, for patients who already treated with cabozantinib, I think for those patients, there will be question about the sequencing to treatment because we will not have the all data about that. But I think for patients who already treated with the cabo, lenva plus belzutifan still can be options. And patients who treated with lenvatinib or other things, again, cabozantinib will be options for those. But I think, of course, if patient already treated with lenvatinib, let's say pembrolizumab or cabo-nivo, for those patients, we need to use which treatment, not use it still.
Dr. Hans, your thoughts on this?
But I don't think we will have an exact answer for any of this sequencing because the treatment landscape always change and the sequencing follow.
Yeah, and I wonder if these patients were excluded, the patients who previously received those therapies.
They have not mentioned that actually in the presentation.
Yeah, there were. There was no prior lenvatinib allowed, for example. So clearly, well, first of all, this is a very important trial because it also went up against cabozantinib. Clearly, this is a very potent VEGF TKI. So this is actually really practice changing for patients you're really worried about. That doesn't need to mean that everybody should start on this combination in the second line. It just means this is a very potent combination. If you have a patient who progressed on prior line of therapy, let's say IO or IO-TKI, and you have a symptomatic patient from disease burden, this is certainly a combination that is worth considering. So it beat cabozantinib soundly, and I think this is a very real option for patients. Doesn't need to mean that everybody should be on it, but it is also, I would say, in my view, a relatively safe pathway to actually get belzutifan included into the treatment schema, because belzutifan itself has this very high PD rate. So this is probably one of the pathways you can get them exposure to belzutifan fairly safely.
So looking at the data, and they have an interim analysis, the first one done in June 2024, then the second one done in April 2025, and the data was presented in February 2026. Probably, of course, it was discussed during the meeting that probably they were waiting for the longer data, hoping that they will end up getting the OS. But these are good results, of course. So this is a very peculiar thing in the belzutifan curve, that there is a tail of curve phenomena. It is typically seen with the IO. So Dr. Senthil, your thoughts on this? That why belzutifan is also showing the flattening of the curve, if you see here.
I'm not too sure there is a tail there, Amol. So I still see that slowly and steadily there are some patients who seem to be progressing. So I'm not too sure there's a tail there. That's number one. I think there is some predictive biomarker in these patients in whom belzutifan seems to be keeping them up with good responses over a longer period of time. I don't think in the clinic we really know which this biomarker is, but I'm sure there's something hidden inside there which helps these patients to be much more sensitive to belzutifan and hence sustaining that response for a longer period of time. So I don't believe that there is a decent curve there as much as you would get in an IO-based treatment. But yes, you're absolutely right that it seems to be much better sustained. And that's clearly reflected in the duration of response, which is almost double of what you're getting with cabozantinib. And that's what is being reflected in that curve, I suppose.
Let
I
me
totally
ask.
agree with that. Yeah, go ahead.
Yeah, please.
No, so I actually totally agree with this. So obviously, this is a palliative regimen. It doesn't cure anyone, but the duration of response is really remarkable, and it reflects, roughly what we've seen with belzutifan, right? Everybody discussed these curves. The truth is, it only works in roughly a quarter of patients, does virtually nothing for all the others, and that's why you see this breakaway towards the bottom of the curve. But the durability of response is remarkable, and some patients can be on this belzutifan-like regimen, like sometimes for years. The question also is, in my view, is if you respond really well to the doublet, you may actually have enriched for patients who may benefit from belzutifan alone. You may even consider dropping the lenvatinib.
Yep. So what about the subset analysis? I know the numbers are not great in the poor risk, but Dr. María, any thoughts on this? No clear PFS benefit in poor risk, or it's too early to say the small subset? Or Dr. Yüksel, can you take this question?
Hello, everyone. Hello,
Yeah,
everyone.
she's there.
Okay. Thank you, Amol, for the invitation. I think the pulmonary disease is biologically aggressive and often less dependent of BCF or HIF. These tumors may have a higher proliferative signaling, more genomic instability, alternative escape pathway. So HIF inhibition alone, even combined with blockade BCF, may not overcome that aggressive biology. Also, my thing is that these poor risk patients often progress early, an early event due to the PFS separation. We see this pattern across multiple renal cell carcinoma trials, and intensification tends to benefit these intermediate risk patients more than poor risk. Does consistency make the signal more credible rather than random, no?
Dr. Senthil, your thoughts on the poor risk subset, or you will not read too much into it?
I would not read too much into it, Amol, because the numbers are too little. So I would not really read too much into that subset analysis.
Okay.
And I don't think you can biologically substantiate unless you say that generally, as we believe, good risk patients are VEGF driven. So belzutifan is working well there. The poor risk patients are less likely to be VEGF driven. So belzutifan is working less in those patients. But with these numbers, I don't think we should give too much of credence to that. I think for me, the more important question, Amol, is, I'd like to ask Dr. Yüksel and others. You start with 20 milligrams of lenvatinib in this study. At least in our patients, Amol, I'm sure you would agree with that, is that it's extremely difficult for patients to tolerate 20 milligram. At least I can't remember the last patient that I gave 20 milligrams of lenvatinib. It's usually 12. We keep struggling getting down to 8. And there's some data that if you're not able to give adequate lenvatinib, the adequate as defined by at least 12 milligrams, then the effectiveness of lenvatinib itself is less. So I'd like to ask other people on the panel what they experience with tolerance. Even in the study, 66% needed dose reduction of lenvatinib. And I think about 25% or so had to discontinue lenvatinib. So how tolerable is this regimen likely to be in the real world, Dr. Yüksel, Dr. Deborah? Because you practice, with kind of patients that we would see here in India.
Yeah. So that is what we wanted to ask. Anyone,
Oh, I'm sorry, Amol, if I asked that question before you did.
Yeah. So,
Yeah, of course.
Bicky, Dr. Hans, Dr. Yüksel, you all use this combination
Yes.
more common
Yeah,
than us in
we
India. We
use.
don't have much access to belzutifan. So how easy or difficult it is, especially lenvatinib 20 mg?
Actually, we use in part of the clinical trial. It is not available yet, but we was in triplet trial, also adjuvant pembro belzutifan trial. So we use belzutifan, lenvatinib, but in most of the time we don't use lenvatinib plus belzutifan. I have a chance to use in triplet clinical trial, which has pembro, lenvatinib plus belzutifan. So still we waiting for the result. It's still not that available. But what can I do during my clinical practice? There is effective dose of the lenvatinib up to 14 milligrams, so dose reduction is possible. And the good thing, even 66% of dose reduction for lenvatinib and 33 dose reduction for belzutifan, there is still benefit in PFS. So it doesn't mean necessarily, because in TKI, most of the TKI, we always try to keep patient under treatment with good quality of the life. So I don't think dose reduction will be related with the lack of benefit. So the best dose is the patient treated. I think the best dose is the tolerated dose
what the
for
patient can take,
so,
per se.
yes,
Okay,
yes.
agreed.
So dose reduction, because even with dose reduction, this amount of dose reduction, still there is signal of the positivity. So I use in the clinical trial also with several doses. Also, I have a chance to use, let's say, lenvatinib plus everolimus. Also in that study, also I start with 18 for most of the patient because 10 and 4 is available in the Turkey. So I think something between 14 and 20 can be targeted dose for most of the patients.
Yeah,
But
this is Hans.
yeah,
So
Yeah.
yeah,
agree,
so
I'm sorry.
go ahead.
yes, Hans, please.
Yeah, so it also depends on what your style of management is, quite frankly, because so I use 20 consistently when I start lenvatinib because these are patients I worry about. So if you start at 14, you're not going to get the effect that you were promised. You start at 20, and the truth is, many patients can actually endure that if you take breaks in a timely fashion, right? So I actually, for example, if they get the diarrhea, I give them a break, everything resolves, and they restart the run, and then they have probably like regular breaks, let's say every 2 weeks, a few days off, for example. And I would say relatively consistently stay at the higher dose level. A lot of my patients actually stay at 20. That works actually quite well. I go down to 14. Obviously, that was the first dose reduction level, but I really don't like to go down any further. And I rather really work with breaks. I would say the patients who really need to be dose reduced, you will know after 2 weeks. If they get in real trouble within 2 weeks, and I don't mean hypertension, I mean like other side effects. Hypertension needs to be managed absolutely aggressively, and you need to be under good blood pressure control when you start.
So, Dr. Bicky, any thoughts on this? Have you used
May
lenva
I
plus
add
everolimus?
short comment, Amol? I agree with Hans. Actually, I do the same. Always start with the regular dose. I don't start with the reduced dose because still some patients can tolerate, and I start with the standard dose, and if tolerated, I continue. Of course, for some adverse event like a hypertension, hypothyroidism, you can manage with additional medication. I don't do dose reduction. But for other things like diarrhea, fatigue, and other things, sometimes also treatment break also helpful for our patients.
Dr. Bicky, your thoughts on this? Previously, we used to have lenva plus everolimus. There's some small phase 2 trial data. Do you use this combination, or what about your experience about lenva plus belzutifan if you used already? Dr. Bicky, are you there?
Yeah. Can you hear me?
Yeah, we can hear you.
Yeah. So I've been using lenvatinib and everolimus, and also like lenvatinib and belzutifan with in the trial. So experience has been both good in both the combination But I think Lenva and Belz is emerging. If we move back to like Lenva and everolimus, I do see response in a patient who progress on cabo-nivo or cabo only. So that is also a good combination of drug. But I do see those responses in my personal experience in some subset of patients, but not all. So that's where like we don't know the biomarker, but do see the response. But I think lenvatinib and belzutifan is also coming up, and still like some of the data are kind of immature in terms of overall survivals, but good to see the like mature data.
Dr. Hans, so as Dr. Senthil has said, that some of the patients with belzutifan are long-term responders. Is there any way to predict, or we don't have any such biomarker as of now?
No, I'm completely incompetent at predicting who responds or not. I have seen very indolent disease not respond at all, and I've seen like very aggressive disease I thought would never respond, do well. Maybe if you have sarcomatoid, there's going to be lesser response, but it's essentially all over the place. And that's why I think actually, one of the advantages of this regimen is that you can actually get the patient to belzutifan without playing Russian roulette. The issue is that if you start someone on belzutifan and take the TKI off, you can have sometimes disastrous disease progression with the 30% of PD rate. And by putting them on both drugs, you may even get into a spot where if you see a really nice deep response, you may even then wonder how much the lenvatinib is actually truly still needed. So there might be some approach where we can be oncologists as well. But I think this is a good combination. In my view, it's better tolerated than Lenev. And in my view, it certainly has more of the efficacy and durability of response.
So Dr. Deborah, do you think, looking at of course, the OS is still not mature, but do you think long-term it will end up getting an OS? And what happens to those patients after discontinuation? Any other salvage options after that? Any thoughts on this, Dr. Deborah?
So in kidney cancer, with all these diseases that we're turning into chronic diseases, it's always quite difficult to get overall survival with the different treatments that patients can have on progression. But certainly if a patient is progressing on this regimen, they can then still have cabozantinib as an option in the third line, as in something that they haven't tried before. With regards to the duration of response, I think that's something that's really interesting, but we have really failed to identify these patients who are responding to any type of anti-angiogenic therapy in advance. So I think this is something that we've puzzled with for a long time. This looks like a very helpful regimen. I think that as Dr. Hans was saying, the combinations with belzutifan are looking more promising than the drug as a single agent. So we shouldn't wait till the end using up all our options before using this as an adjunct to other therapies.
So thank you. Moving on, this is another study, LightSpark 022. This is the talk of the town for the ASCO GU 2026. Adjuvant pembrolizumab plus belzutifan versus pembro alone for clear cell RCC carcinoma. It's a randomized phase 3 trial. It is a very large trial. They have close to, if I'm not mistaken, more than 700 patients in each arm. So pembro plus belzutifan versus pembro alone. Now, this is something which is interesting. They have taken, of course, metastatic M1 NED. And the previous keynote trial, they included patients up to 1 year post-surgery. In this trial, they included patients up to 2 years. So, Dr. Bicky, Dr. Hans, any reason why you think that they are extending this span of M1 NED from previously 1 year post-surgery now to 2 years? Any thoughts on this, Dr. Hans?
Yeah, so I think it's actually reasonable to do that because I would say where the surgical data gets really strong is really after 2 years, where you really have a probably more curative approach to metastectomy. 2 things here. First of all, we don't have the breakdown officially, but I think Tony Cherry indicated that the vast majority of those patients enrolled in this subgroup were actually recurring within the first year. So I think good to look at. The other one is, to be honest with you, in my view, that's a patient population that actually shouldn't exist, because if you recur within the first year, by definition, you have intermediate risk disease, And if anything, the data has shown that those patients should not go for surgery, but they need immunotherapy. You need immunotherapy. Even if you resect it, you need immunotherapy. And I think you may do better with combination immunotherapy, dual immune checkpoints, rather than pembrolizumab after resection. So that's a little pet peeve of mine. Those patients, when I see somebody recurring within first year, actually don't do metastectomies. I actually offer them dual immune checkpoint inhibition, still with curative intent. And if they don't respond to that, then you can still resect.
So Dr. Senthil, again, this is an interesting subset analysis. If you see Keynote 564, the M1 NAD subset has the maximum best response, hazard ratio 0.4. But in this particular trial, it is in fact not that great. So again, are we looking too much into the subsets, or what's your thoughts on the M1 NAD for this particular trial, Dr. Senthil?
Yeah, so
go
yes.
ahead, Dr. Hans. I was going to say that it's a very small subset of patients, 6% of patients, and based on 6%, I don't think we need to come to any conclusions on the efficacy or the lack of it, Amol. So I would just let it pass. And then if you have the right candidate for a treatment like this, you go ahead and use it, is what I would think.
Yeah, Dr. Hans, your thoughts on this?
Yeah, this is certainly surprising. So, you know, in the original Keynote 564, obviously this was a group that even had an oversized impact, if you will. It was like only 5% of the patient population, but contributed, I think, 10% of the events. So to say, it is a little bit surprising to me. I don't have a good explanation, and we will see how that develops. But maybe, and there was some of the discussion, maybe bezutifan is targeting the little bit less aggressive disease, but we don't know for sure.
Dr. Bicky, your thoughts on this?
No, that kind of clearly explained, like, you know, as I agree with the Dr. Senthil, that small subset, but also like it was Pembro now with the belzutifan, still like we don't know, like, you know, a little bit surprising, but certainly there is a kind of, we are seeing benefit of the Pembro, but how much we are adding belzutifan and getting benefit with that, still we need like more data.
So again, of course, the toxicity profile is well versed as per the previous trials with belzutifan, and most of the toxicities were manageable, as was discussed Dr. Chori in the discussion. But so let me ask all of you that are we overtreating some, if not all, patients postoperatively, or will you wait for the OS? Suppose if it gets approval based upon DFS, are you okay to use it? So let me start with Dr. Yüksel. And Dr. Natalia, Dr. Deborah, what's your thoughts on this?
Actually, for adjuvant trial, I think the tolerability is and toxicity is more. I have a more concern when I get to adjuvant treatment because we already have a treatment in hand with overall survival benefit with pembrolizumab. So I think this is important result. This is the significant result for disease-free survival. But I think to be able for practice change for those patients, I would wait for OS data.
Dr. Hans, you will wait for OS or?
Yeah, the same.
I
I do need to see OS, and obviously they were powering it to see OS. The absolute difference, I think, at 2 years was only 0.5%. So I'm not sure they will reach OS, to be honest with you. Yeah, I'm in no rush to adding it on.
Dr. Senthil, your thoughts?
Absolutely. I would wait. At least I'd like to see a better hazard ratio for even DFS. 0.72, I think, is quite modest to be able to take so many toxicities for the sake of that modest benefit. I don't think most patients will agree for that. And of course, the cost comes in situations where all of us practice. So not immediately, but I'd like to wait for some more data before I decide.
Dr. Deborah, your thoughts on this?
Absolutely. I have to agree with all of our colleagues. But in the end, if this is going to be curing more patients, then it's a discussion to be had. And it's not just the physical toxicity, it's the financial toxicity as well, this treatment. But if this really is, or if we can identify the subgroup of high-risk patients that this is really benefiting, then it will be that risk-benefit discussion with our patients in the clinic once this is approved.
Dr. María?
Yes.
You'll wait for the OS or you're okay for DFS benefit?
Okay, I'm okay with all the commentaries. Just to say that the disease-free survival is an important endpoint, as we know, but in this setting, in adjuvant renal cell carcinoma, overall survival is the endpoint that change comfort and weak comfort, no? And we escalate treatment for high-risk patients with a biological enrichment with risk replacement, recurrence, anxiety with a treatment burden, for example. And I wait, I'm comfortable waiting for the results. And regarding the toxicity, even if manageable, these are not trivial in patients without radiographic disease. So for me, the key question is, are we improving cure rates or are we delaying recurrence in some patients while overtreatment others, for example? And until overall survival mature, that questions uncertainty remains. No?
Yeah, Dr. Bicky, it's your trial, Dana-Farber's trial. You will wait for the OS or you're happy with the DFS?
That's a very good question and strong question. I mean, I agree with all the panelists that generally we need overall survival and any
Dr. Bicky, Dr. Choudhury is listening. So
yeah. So certainly nothing is free of cost. So certainly there are a lot of stakes. So it's funneled down to like regardless of like overall survival data is good, but at the end of the day, like what patient selection funneled down to that. I would not treat patients who have like extensive cardiac disease and hemoglobin is persistently below 10. Even if there's overall survival benefit, the toxicity gonna be quite high. So patient selection is the key in this case. But certainly, for a younger patient who have high risk, even a little bit risk factor, certainly I'll do that.
So,
Thank
any one
you.
of you have used KIM1? I think Dr. Hans, have you used KIM1, kidney injury marker 1 as a biomarker?
Yeah, I have been begging my pathology team to get me access to that. I have not been able to get it commercially available at my institution, but I would love to use it. To be honest with you, I think all the data, the aggregate data work that's there out there in kidney cancer is probably one of the most exciting biomarkers that we have. As you know, we are suffering from a lack of circulating tumor DNA in this non-shedding cancer entity, and I think KIM1 could really make inroads. So this is something that will come. In principle, it's a fairly inexpensive test, but hopefully the companies will give us more access to it.
Okay, so Dr. Piquet, are you using it in your institution, KIM1? Or anyone
No,
else is
still,
using KIM1?
yeah, no, it's still research phase. We are using it as one of the biomarker in trials as exploratory analysis. So certainly this is emerging, and Dr. Zhu, one of our colleagues, is working specifically on that. And certainly the ctDNA genome based are showing some signals. So more to come, but not using clinically, not yet prime time.
Okay. So as we have discussed, most of the faculty will like to wait for the OS for the Pembro plus Lenva, but the DFS data is impressive. But what about the other trial in which the Lenva plus belzutifan combination? If it gets approved, how keen are you to use it, Dr. Deborah? If it gets approved and belzutifan is accessible.
Yeah, absolutely. I think our normal second line would be cabozantinib for patients that haven't received that. But now I think we have very good, solid data that this new combination is something very promising. So I think once it is approved, it will be used.
Dr. Senthil?
Yeah, I agree, Amol, that though there isn't an overall survival benefit still, it's very difficult to show overall survival benefit for kidney cancers in the metastatic setting because some of them go on from one TKI to the other to the other. So I think the data that we are seeing in terms of response, duration of response, is quite impressive. And if available and our patients can access it, certainly it's one of the options.
Dr. Hans, for the metastatic second line, are you happy with lenvatinib belzutifan if it gets approved?
I think it's a great option. I'm not sure that everybody needs to start on it right away. Personally, the way I think about it is once you progress on immunotherapy, this is all palliative. And you really have to look at the patient and see how can you improve quality of life. The lenvatinib obviously takes away the unique quality of life that you see with with belzutifan monotherapy. And so there are some patients who may start on on a more selective VEGF TKI such as tivozanib. And then I used to go to cabozantinib when I'm worried about them. In this case, this would be now the place for len-bel, and then reserve cabozantinib for later.
And I
Thank you.
would also like to add, Dr. Hammers, that the
Yeah.
cardiac toxicity was higher in the belzutifan cohort as compared to the just cabozantinib. That is one thing to consider in patient selection with len-bel.
100% agree.
Yep. Thank you. So now
Yeah.
moving on, if we have some time left for the important discussion of the bladder cancer abstract, that is the neoadjuvant and adjuvant enfortumab vedotin plus pembro for participants with MIBC who are eligible for cisplatin, randomized open-label phase 3 keynote B15 study. Now, this is something that I wanted to ask Dr. Deborah. On one side, you are giving 12 weeks of therapy, and on the other side, you are 27 weeks of EV Pembro, 24 weeks of more of Pembro. So is this your current standard, the control arm is your current standard of care, or you're okay with this?
So now we have, as our current standard of care would have been neoadjuvant chemotherapy, followed potentially by adjuvant immunotherapy. So I think that's what might be missing from our current standard of care. But of course, when these studies are designed, standards of care evolve with time. So I think that this is expected as per the time of design of the study.
And what about this definition of EFS? Dr. Senthil, they have added presence of biopsy-proven residual MIBC or any radiographic disease for patients who did not undergo surgery. This is an addition to the conventional event-free survival definition that we see. So are you happy, or what's your comments on that?
It's not a question of whether I'm happy or not, Amol. I think it's a question of how important this kind of a criteria is to be part of event-free survival. For example, if you go back to the Niagara study, one of the criteria for event-free or an event was if you don't get to surgery on time, right? So I think there's a lot of variability in the kind of factors that go into making this event, to being counted as an event. How relevant is it? It becomes very relevant if there are too many patients who fit into one of these two criteria, which are soft criteria, I would say, which would end up, influencing the outcome of the study. But I think there will be very few events which will qualify with one or two of these. So while, I would like to have uniform definition for event in bladder cancer studies, till then, I think we should keep a watch on the other criteria that fit into this, this definition.
So at least
of
when there is a full
event.
publication, we should be able to see that the EFS with this particular event, how many events were there. I mean, generally, that disclosure is also not there. I'm not so sure.
Correct. So I think you can roughly extrapolate it from the percentage of patients who didn't have surgery, right? Right. Partly, at least, the criteria that you have highlighted, that can be roughly extrapolated from the percentage of patients who didn't have surgery but didn't have complete response on the scan. So to a certain extent you can, but you're right that till you get all the numbers, you'll not be able to really say that this influenced the outcome.
Dr. Natalia, your thoughts on this? The
Yes,
EFS?
I'm comfortable with the EFS in this context. Of course, we need more results, of course, but in perioperative trial, EFS captures the events that are clinically meaningful. For example, progression before surgery, inability to proceed to cystectomy or death. And for patients, those are not soft endpoints. We need to be very careful with that, and they reflect real consequences for our patients, and for the quality of life of our patients. In a curative intense settings like massive invasive bladder cancer, overall survival still matters the most to me, but the EFS is not a bad endpoint for the quality of life and the evolution of life in our patients. Besides, we have too many options now, and too many options for sequencing, and the intensification and therapy upfront is one of the most important points for me.
Yep. So looking at the patient disposition, Dr. Yüksel, 25% stopped the neoadjuvant EV Pembro, 28% stopped the adjuvant EV Pembro, only 51% completed perioperative, the entire protocol. So 49% could not complete the full course in a trial setting. So do you think this will be easy to implement in the real world? In the real world, maybe the number will be more or less?
Yeah, this is both fortunate and unfortunate. It's fortunate because the landscape change very rapidly and we get different option for our patients. Unfortunately, when we get the data, and most of the time, it makes standard arm outdated. So there will be always question about whether the standard arm of the treatment is really standard of care. Because we know even this is the standard of care. Cisplatin gemcitabine is standard of care in most of the world, but it is not best treatment available for control arm because we have several others like a Gemcis plus Durva and Niagara Data. So of course I will want to know what is the response and what is the oncological outcome of those 28 patients, but it will not change the general picture because the number is too low. I think at least half of the patients couldn't complete the full course of the treatment, which is bring my mind this question because when I started design of the study, I asked same whether those patients really need EV after the surgery because we have more than 50% of the CR, pathological CR. And I think now the next question will be in which patient we need to continue with EV. I think for most of the patients, of course, this need to be asked and tested, but this is my personal opinion. For most of those patients, especially with patients with PCR, adjuvant pembro only will be enough. Even in patient with ctDNA, if there is a possible to be able to look after the surgery, even in patient with ctDNA negative result, even maybe observation will be the choice. So we need now we have several effective treatments, but now it brings us different question. For example, which patients need EV after the surgery, which patients need pembro after the surgery, and also with ctDNA and with utDNA pre-surgically, do all patients need to go cystectomy? And if patient goes cystectomy after the cystectomy, do they really need any adjuvant treatment? That is the question we need to ask for the coming days for the new trials.
Yeah,
Dr.
just to
Senthil, your
add,
thoughts about the control arm and only 28 patients receiving adjuvant IO?
I agree with Dr. Yüksel in the fact that this is probably not the best arm, but it is one of the arms that many of us still use in practice. For example, in our own country, a lot of patients can't get durvalumab. So if most patients can't get durvalumab, the real world standard of care ends up being gemcitabine and cisplatin. We would have loved to see Niagara as the control arm, if not Niagara, at least the keynote, the 264 study as the control arm. But unfortunately, at the time this study was conceived, it's probably not the standard of care. So this is a moving target, right? The control arm is a problem now with most of these studies. So I'm kind of okay. At least it's not placebo, right? So I'm happy that way. So that there was at least neoadjuvant chemotherapy. But all the questions or points that Dr. Yüksel raised are very relevant. Who needs EV? How much EV? How long EV? Do they really need EV? Do they really need pembro itself? So I don't think we've got answers to any of these questions. I don't think you will get a clean study trying to answer each one of these questions also. So you'll probably need to extrapolate results from, let's say, IM bigger 011 to, the EV304. So scientifically not the best thing to do, but I think real world practice, depending upon what patients like to do and not, we will kind of cross compare and extrapolate from one study to the other is what I feel.
Again, about the subgroups, you will again not look too much into it, Dr. Senthil. Dr. Bicky, any thoughts on the subgroup analysis? Because they are from the forest plot. And of course, some of those hazard ratios are crossing unity.
Yeah. So certainly not. The numbers are small, and there are a couple of things in terms of disease biology and trajectory. I also do see a lot of non-muscle invasive bladder cancer. Sometimes I feel that T2 muscle invasive is like better than the extensive non-muscle invasive bladder cancer. So certainly in this case, so if we have to look at like before we start the neoadjuvant or perioperative chemo is that a patient had second TURBT and complete resection, that T2 disease, then that's kind of complete resection of the tumor and minimal disease. So certainly that is not surprising looking at the numbers and also crossing the hazard ratio.
Dr. Deborah, looking at the toxicity, there is almost 7-8% difference in the toxicity. But do you think the GC is that toxic in the real world?
Not really, but I think I think that the EV Pembro is really not terrible, especially for a short duration of treatment. So, this is something which we're now learning to manage. We've had experience now in the metastatic setting. So I think we are getting used to managing and offsetting the toxicities of EV Pembro. And if we think about the comparing trials, this has really given us the best landmark survival at 2 years of any neoadjuvant study, including Niagara. So I think that if we are able to intensify treatment upfront, this is excellent for patients. And the de-intensification is going to be very, very pragmatic. It's going to be patients who drop off treatment due to toxicity or lack of access. And hopefully these patients could be included in registries in the real world setting.
Thank you. So, Dr. Senthil, now this is, of course, not an advisable thing to do, a cross-trial comparison. But Niagara is not doing that bad, right? And we are used to use IOs. We are able to manage the toxicities. So, what's your thought on the cross-trial comparison?
But I think you'll also have to see what the comparator arm is doing, Amol. So you see that the comparator arm is also doing much better in the Keynote B15, right? The gemcitabine cisplatin is also
Yes.
doing. So I think when you compare trials, it's always good to look at the hazard ratios. So if you look at the hazard ratios, certainly EVP seems to be giving you a better hazard ratio compared to gemcitabine cisplatin when you cross compare it with the Niagara study. So I don't think we would use that number to say that Niagara is not doing badly. Certainly, EV Pembro is doing better, but I think we come back to those questions that we've been asking all the while: who needs what, how much, and so on and so forth. For example, if you have a T2, I do ctDNA at the time of diagnosis, the ctDNA is negative. Do they really need to go through this whole conveyor belt approach of EV Pembro and then EV Pembro after that, and so on and so forth? That patient with cystectomy plus minus an IMvigor 0 kind of a strategy is really going to do very well. So should all T2s end up getting Keynote B15 is an interesting question. Is radiology a good way of assessing status in bladder cancer? For example, in B15 itself, if you look at investigator radiology assessment versus the central assessment was what was taken for the study. If you look at the investigator, 70% of all were T2s, which is not the case with the central. It was much less. I think it was 30 or 40%. And a lot of these patients end up having lymph nodes. So I think there are so many intricate issues and nuances that one has to take into consideration when you're really sitting with the patient and discussing these data. It starts with prognosis, defining prognosis, and then looking at how these new treatments can impact outcome, toxicity, both financial and physical.
So the same question that Dr. Yüksel and Dr. Senthil has raised, that how much is the adjuvant portion necessary? So do you think, Dr. Yüksel, in future, based upon the ctDNA used either from the blood or from the urinary tract ctDNA, we'll able to get rid of at least the adjuvant part if the patient shows an excellent response in neoadjuvant setting?
I think UTDNA mostly will be helpful for preoperative setting, because after the surgery, still we need to validate the result of the UTDNA. But definitely, preoperative setting, predicting pathological complete response rate, it's better than ctDNA, because we know in patient with ctDNA negative diseases, still half of the patient has residual diseases in bladder. So I think in the future, to be able to decide using UTDNA and the ctDNA together will be more helpful for our patients. But still, I think the question is still there, still relevant, and we need to ask which patients need adjuvant part, both for EV and also with Pembro. So as a ADC, and mostly is like a chemo, of course, we have a different result from other tumor. When you have, for example, for breast, after the anti-HER2 treatment, if you have a residual diseases, treatment with ADC provide benefit. We cannot say without tumor out there, ADC will not get benefit. There is some other example from the other tumor. There is still expected benefit, but patient with pathological CR, I don't think we need additional EV after the surgery. But for those patients, of course, Pembro will be still valid option. But of course, these two questions need to be tested in future trials.
So,
So,
Amol, I just want to make a point. Sorry to interrupt, Amol.
yeah.
So, just to an extension of what Dr. Yüksel was saying, I think the ctDNA analysis of Niagara is very, very informative. You can nicely stratify patients. You've got a set of patients who've had both PCR and ctDNA negative who do exceedingly well. And then you've got a set of patients, ctDNA negative next. You've got PCR with ctDNA who's still positive. So I think you need to learn to stratify these patients and prognosticate them well post-surgery for you to then make a calculated guess based on all this information as to how much these patients will need post-surgery. So that's a very difficult thing to do, but I think that's where we need to get to.
Now, this is the crux of the matter now that we have so many options available. Is that Dr. Tom Powell said in his talk, give EV Pembro first, ask questions later. So for all that, all MIBC patients, whether it's cisplatin eligible, non-eligible, first thing is to give EV Pembro and then ask questions later. So do you think, Dr. Bicky, this is where we are heading in bladder cancer? Give EV Pembro first, irrespective of cisplatin eligible, non-eligible.
Yeah, no, this is like really good thought. So, and I before this data is out, I have been giving like EV Pembro for my patients. So trying to make if there's a little bit locally advanced or something, and I'm seeing excellent response and keeping eye on their toxicity. So certainly, this is, and I'm also seeing like complete remission after 1 year and not requiring treatment in metastatic setting. So EV Pembro is game changer and one of my favorite regimen. But it also comes with a cost, which is like toxicities, and most of the patient doesn't go beyond like 4 or 5. So we have to be very cautious how much, how long, and we can give this drug. So there are good example in my clinic and good experience, but with a caution of toxicity and also like financial toxicity, I would say.
Dr. Deborah, so where will to fit Niagara, or that is now outdated? It is only presented 1 year back and now it is outdated.
This is the pace of change. There are definitely many patients around the world who will not have access ever to EV Pembro. And in terms of cost effectiveness, it's going to be very, very challenging to make that argument in all healthcare settings. So I think that if we can, so there will be patients that are still eligible and may have access to chemo development and not have access to EV Pembro. If we can bring down the cost of tumor-informed ctDNA monitoring, this is also potentially going to help cost effectiveness. So will patients still be on the Niagara regimen? Yes, there will be patients. There'll be patients around the world still taking neoadjuvant chemo alone? Absolutely.
Dr. Senthil, nobody for post-op nivolumab in today's era now?
Not immediately. I think it's easy to lump everybody together and then say, this is what I want to do, Amol, because it's very difficult based on the available data to say who should have 264, who should have Niagara, and who should have EV Pembro. In real world, instead of confusing patients, it becomes very easy to do this. But for a scientific discussion, as I said, T2, clinical N0, ctDNA negative at the time of diagnosis, am I okay to just do gemcitabine cisplatin for this patient, look at ctDNA afterwards, and then decide what I want to do? I'm fine to do that. It's good for a discussion here, but it's very difficult for us to make patients understand this and tell them, okay, for you, this is enough, and that is necessary, and so on and so forth. So in practice, we all end up lumping patients together and treating them the same way, though all of us understand, all of us know that that's not the best way to treat patients. We're doing this very suboptimally, but that's where we've gotten at this point in time.
Professor Yüksel, do you think any patient ever should get surgery first in today's era with urinary bladder, or the neurosurgeons are now getting outdated?
Actually, I believe even surgeon, as at least most of my friends, not happy with radical cystectomy. It's not easy surgery and complicated surgery, and definitely affect quality of life of the patient. And if we have really very good alternative to cystectomy, I think there will be less discussion comparing with radical prostatectomy. So surgery, I think at least for several patients should be part of the discussion and not first thing to do, I think, for today.
Yeah, this is where the field is moving. This is the next trial that is coming up, EV Pembro plus RT. That means addition of a local RT to EV Pembro as a neoadjuvant and then going for bladder preservation. I think we're running out of time. We have another beautiful data from Tom Powell about the DV study. Now, quick thoughts. Again, will ADC work after the ADC? The discussion was that probably with the same payload is not going to work. So we don't know how this data will be useful, but there are studies now, along with the EV Pembro, there is a thought of DV Pembro also. So
Yes.
again, we'll have too many options, too much of confusion. So probably after 6 months, we'll be talking even another option, whether to give EV Pembro or DV Pembro.
Yeah, actually, in our center, we have a DV Pembro trial still ongoing, and we recruit patients. And there is some data about the EVP in HER2 positive diseases. And it seems in HER2 positive diseases, EVP not good as like a HER2 diseases. So I don't think there will be head-to-head trials, but whenever you have a driver, I think if both available and DVP trial show positive result, my primary choice for those patients will be DVP, but I need to see the data, of course, for those patients.
The available data, Amol, says that the PCR with DVP is higher than what you're getting in 303 and 304.
Yeah.
This is about
Yes.
55, that's about 67% or something. So
Yes.
it's much higher.
Yeah, but the DV Pembro trials are still phase 2 trials. We still
Yeah.
require a bigger
Yeah,
data.
you're right.
Yeah, and other DVP. Actually, in our center now there is again phase 2 DVP versus DV versus DVP in HER2 disease. Of course, we include any type of the HER2 positivity, not only HER3 positive, HER2 low diseases also. So I think we need to. But I also would be happy to see post-hoc result of the keynote 839 EVP 302. What is the efficacy of the EVP in HER2 positive diseases? I think we didn't see the result yet. Did you see?
No. It's
No,
not.
okay. Okay.
Yeah. So moving on, last few slides, role of ctDNA or urine ctDNA. It was discussed here. It is, as of now, definitely prognostic, not necessarily predictive. So are we routinely doing it? Dr. Natalia or Dr. Deborah, are we doing this in clinical practice? In your practice, are you doing ctDNAs for bladder cancer?
Not yet.
Dr. Deborah?
Not yet. We do have access to Natera assays, but again, it's something which is not done routinely in clinical practice.
Dr. Bicky and Dana-Farber, are you routinely doing it?
Yes, I'm doing it, this thing, and luckily Natera, some of the commercial testing companies, they are kind of waiving off the insurance or doing it for free of cost for patients if insurance is not covering. So this is one of my good biomarker area where I really like the ctDNA for risk stratification in my clinical utility as well. I agree it's prognostic, but I think there are a few things that we have to consider about is that Signatera, we have a lot of data from Signatera, which is like 16 variant and exome based, as compared to if there's a genome based, which could be more sensitive, and they are claiming that to be from like RCC and other distinct malignancies. So I think it's a lot to come. So main thing is that standardization of the testing. If the ctDNA, tumor-informed ctDNA, then how good the standardization and also like how what is the sensitivity looks like, because there are some patients who are ctDNA negative was not correspond with the pathology like a PCR. So we have to keep in mind. And also like urine cell-free DNAs, it's emerging. And when I talk in the background, we don't know what the pre-analytical and how urine is preserved, how that is processed, and have ctDNA, this thing. So it's too early for the urine ctDNA, but it will be really helpful and good piece of information to risk stratify and also like prognosticate for de-escalation or escalation of the treatment.
So basically, like Kim1, the urine ctDNA is the upcoming marker, along with, of course, the ctDNA from the blood-based studies. So I think we are running out of time. Is there any audience question? Is there anybody from the audience wants to ask anything specifically? Otherwise, I think we're already 10 minutes over. So let me thank my faculty for joining from all over the world, Dr. Yüksel, Dr. María, Dr. Deborah, Dr. Hans, Dr. Senthil, and Dr. Bicky. And we hope and pray for peace all over the world, especially in Middle East. Dr. Deborah, hopefully you will reach your home on time and sooner.
Thank you so much
Take
for
care.
this wonderful webinar and
Thank you.
always bringing us all together globally to advance science and patient care. It's absolutely wonderful.
Thank
Thank you, Amol. Thank you, Amol. Had a good time.
Thank you.
Learned a lot.
Thank you,
Thank
Amol.
you. Thank you.
Thank you for the invitation.
Great.
It was
Thank you.
wonderful.
Thank you.